Good evening, friends. In this video, we are going to discuss about the role of gut prophylaxis in neurocritically ill patients. We know that whenever there is a neurological disease and a patient is critical, then the abnormality produces similar changes in the gut because gut and the brain is a part of the same axis which is known as the gut-brain axis. This was first pointed out by Karl Rokitansky in 1842, who observed that in patients with brain tumors, there were certain gastric erosions and gastric ulcers. And in one or two cases, these ulcers extended beyond the stomach into the duodenum. Now, this was further explored later by Harvey Cushing, and who observed that this hypersecretion of gastric acid is the predominant factor which gives rise to ulcers in the stomach. And this became known as Cushing's ulcer, also commonly known as the Rokitansky-Cushing syndrome. And it was implicated that it is the vagus nerve which is responsible because the vagal nuclei, which are located in the medulla, instigates these changes, giving rise to an increase in the secretion of pepsin and gastric acid, which produces ulcers in the gut. Now, this is not the only factor which was subsequently found out later. And today, we know that a multitude of factors are responsible to produce these changes, which affects the entire length of the gastrointestinal tract and not just the stomach or the duodenum. Now, let us take this illustration as a case, and as we walk along this, we will be able to figure out what are the changes that takes place in the gastrointestinal tract following any traumatic brain injury, intracranial hemorrhage, or such forms of damage to the brain and the spinal cord. A 28-year-old female with motor vehicular accident and traumatic brain injury presents to the hospital with a GCS of 8, E2M3V3. The CT reveals intracranial hemorrhage with hematoma and midline shift. The patient undergoes decompressive craniotomy and is on mechanical ventilator for 2 days. Now, what are the effects of this injury and the subsequent course of illness, that is the neurological illness, on the gut? Now, why this 2 days is important? Because it has been found that the effect of this vagus, which stimulates the release of acetylcholine, that acts on the M3 receptors of the parietal cells, and that ultimately activates the sodium hydrogen ATPase pump, which produces an excessive gastric acid secretion as well as excessive pepsin secretion. This peak effect is within 3 to 4 days. So a patient who is on mechanical ventilation for 2 days following the injury is likely to have a peak effect within a day or so. So in this context, if you know that what are the ways or means by which can we prevent these changes which may occur in the gut. Now, whenever there is a traumatic brain injury, that it may or may not produce a rise in the intracranial pressure. If it produces a rise in the intracranial pressure, that gives rise to a lot of other changes. The first is the autonomic abnormalities that I told was largely mediated by the vagus, which affects across the parasympathetic nervous system distribution. And therefore, the gut, which has large parasympathetic supply, gets affected. So this affection is in the two forms. One, as I told, is in the form of the development of erosions on ulcers. And if the ulcers are deep, then there can be GI bleed. And second, in the form of ileus, which affects mainly the intestine. It can also affect the heart, producing cardiovascular disorders. It can produce pneumonia. And if there is GI dysfunction, it can involve the stomach or the small intestine. As I told you, this intestinal dysfunction is mainly in the form of ileus. The stomach dysfunction is mainly in the form of erosions and ulcers. In the intestine, this paralysis or the ileus may be because of an account of villi necrosis or deformity, prolonged ileus, then ileus dysfunction, that is the recovery is delayed owing to the presence of various inflammatory substances and increased permeability of the intestine. However, it is also important to know that whenever there is splanchnic hypoperfusion, the mucosal cells of the gastrointestinal tract, which are largely the protective elements of the gastrointestinal tract, they suffer a lot. And when they suffer, this erosions takes place easily, and all the protective functions of the gastric mucosal barrier can be affected. Now, this mucosal barrier can be affected as a result of increased pepsin secretion, increased gastric acid secretion, true. But they can also be affected because of reperfusion syndrome. That is, if there is low perfusion for prolonged period and followed by a sudden increase in the perfusion of this gut mucosal cells, then there can be hyperemia, and this hyperemia can lead to cell death, and that can also cause all the GI changes of ulceration, bleeding, paralysis, etc. So the whole thing is quite complex. But if we want to preserve the integrity of the gut, then understanding these changes in the context of a gut-brain axis is important, because only then the coupled treatment to treat one cause and also to get its benefit at the other end can be achieved. Most of the time, it is seen that endoscopy is performed within 72 hours of a major burn, where we call it Carling's ulcer, or a cranial trauma, Cushing's ulcer. They reveal acute mucosal abnormalities in more than 75% of the patients. Although this is very high, there is no it has not been found that this actually increases the mortality. But definitely, in those patients where the incidence is very high, they can have a very high degree of morbidity. And there are certain complications which are very common in such morbid patients that can secondarily increase their death rate. Now, this stress-related gastric mucosal injuries have typical characteristics because they typically occur in the acid-producing areas of the stomach, which is the corpus and the fundus, because of the involvement of the pepsin, which damages the mucosal cells there. It involves small erosions that usually do not lead to bleeding, but if they go untreated, they may develop into deeper ulcers, which can cause bleeding. And they tend to cause GI bleeding without associated abdominal pain. So when the abdominal pain is not there, so there is unlike to be any complaint. So it is observed only when by detection of altered blood in the stool and a dip in the hemoglobin. So there is a need for prevention and also for early diagnosis. Now, if we are to understand the risk factors for stress ulcer related bleeding, there are many factors which are in common with other critically ill patients, that is the non-neurological critically ill patients. But they are all significantly more pronounced if a patient has a neurological disease, like respiratory failure requiring mechanical ventilation for more than 48 hours, coagulopathy, acute renal insufficiency, acute hepatic failure, sepsis, hypotension, severe form of head or spinal cord injury, anticoagulation, if a patient has history of GI bleed, low intragastric pH, though it is difficult to determine at many always, if there is thermal injury involving more than 35% of the body surface area, in cases of major surgery lasting beyond 4 hours, administration of high dose of corticosteroids, that is 250 milligram per day of steroids or equivalent hydrocortisone, and presence of acute lung injury. Now, all of these are common in non-neurological critically ill patients also as cause of ulcers, stress ulcers, but it is more pronounced in patients who have some form of neurological injury. And if we look into the risk ratio, we find that the NSAIDs, they have a 3.7 times greater risk of stress ulcer if the patient is on NSAIDs, followed by coxibs, the rofecoxib, and Another thing which is important, that in patients who are on dual antiplatelets, that is clopidogrel and aspirin, it has been also shown that in those patients there is a greater risk of ulcerations or erosions in comparison to those who are on single antiplatelet. So, having known this, neurological injury combined with severe physiological stress, critical illness have always shown to increase the risk of GI ulcer and subsequent hemorrhage. So, gastric ulcer prophylaxis is recommended if there are at least one major or at least two minor factors. And in these patients, it is seen that higher the risk, the better is the expected benefit of undertaking a prophylaxis. So most clinicians choose to modify or discontinue when the enteral feeding is resumed or when patients are transferred out of the ICU. So what are the major risk factors? These are mechanical ventilation and coagulopathy. The minor risk factors include sepsis or severe hypotension, acute renal failure, hepatic failure, severe head or spinal cord trauma, history of GI bleed, more than 35% burns in the body surface area, surgical duration of more than 4 hours, and high dose corticosteroids. So therefore, it is very important to understand and recognize this risk factors at the earliest so that definite corrective measures can be taken if there is already some kind of ulcer, or if there isn't any, then to prevent them. So what are the choices available for prophylaxis? One, we can give H2 blockers, and they develop tolerance. That is the histamine receptor 2 blockers. They develop tolerance after 72 hours. The PPIs, they are potent, long lasting, but the maximal effect takes time, 2 days. Sucralfate, this is produces a coating, so it is less effective than H2 blockers in found in some studies. Antacids are not a viable option for labor-intensive dose regimes. They are required in high doses, and we know that they can produce certain side effects, including metabolic alkalosis and hypophosphatemia also because of their phosphate binding properties. And also they can lead to diarrhea and constipation, like magnesium containing the antacids will lead to diarrhea, while aluminum containing antacids can lead to constipation. So out of these choices which are available, we have to choose the one which can take care of the maximum. Most of the time, it is the PPIs which is chosen, although at times sucralfate has also been found to produce added effect. So all reduce the frequency of overt GI bleeding as compared to placebo or no prophylaxis. Now, if you look into this study, which is the systematic review and meta-analysis of all the randomized controlled trials, they have found that in stress ulcer prophylaxis, what is the efficacy of safety of the proton pump inhibitors? They said that stress ulcer prophylaxis use was associated with significant reduction in bleeding, but not the mortality, as I had told before. And therefore, stress ulcer prophylaxis should not be abandoned until large randomized trials demonstrate the futility of this intervention. So this systematic review supports stress ulcer prophylaxis in the patients. So despite having any lack of any effect on the overall mortality. So then what are the complications of stress ulcer prophylaxis? In general, there can be drug allergy if any of the components of there, drug side effects and drug interactions, and pneumonia. Now, this pneumonia is one of the causes why people are scared about using PPIs. And sometimes it is felt that H2 blockers are probably less likely, but most of the time studies have not found any difference in the occurrence of pneumonia between H2 blockers and PPI, and they have the same propensity to cause. The PPIs, in addition, can cause interstitial nephritis. It is rare, but one of the major side effects. Clostridium difficile enterocolitis is also sometimes may be found, and or Clostridium difficile associated diarrhea can be found that This is dose dependent, and if we can stop the drug or reduce the intake, then it can reverse GI upset and headaches. And also long-term use can be associated with osteoporosis leading to fractures, then hypomagnesemia, hypocalcemia, etc. So there are problems with the use of PPIs as well, but they are probably the most useful among the whole list of stress ulcer prophylaxis agents. H2 blockers can have a tolerance after 3 days, so their effect will not be visible. And in the elderly, they are likely to produce some CNS side effects. So currently, if you look into the recommendations for stress ulcer prophylaxis, we have the SCCM recommendation, the DASIM recommendation, that is the Danish Society and of Anesthesiology, and the Danish Society of Intensive Care Medicine. We have guidelines from the Eastern Association of the Surgery of Trauma, and everywhere it is PPIs or H2 receptor agonists. It is weak recommendation. And except in Eastern Association for Surgery of the Trauma, where PPIs or H2RAs or cytoprotective agents like sucralfate are also recommended. The indications for prophylaxis according to the SCCM and ESICM Surviving Sepsis 2016, the patients with sepsis or septic shock with risk factors for GI bleed, which includes mechanical ventilation for 48 hours, coagulopathy, pre-existing liver disease, need for renal replacement therapy, and higher organ failure scores. So these are almost similar to the non-neurologically critically ill patients as well. Whereas if you look into the Eastern Association of the Surgery of Trauma, they have in addition have an injury severity score of greater than 15, or patients receiving high dose of corticosteroids. This has been added, and also ICU patients with polytrauma. So more or less the guidelines are equivocal in regarding the choice of the agents. So whenever we have to assess whether the patients require stress ulcer prophylaxis, we can look into any of these factors: coagulopathy, mechanical ventilation for more than 48 hours, peptic ulcer disease or GI bleed within the last year, a GCS of less than 10, thermal injury to include more than 35% of the body surface area, partial liver resection, multiple trauma with an injury severity score of more than greater than 16, and hepatic or renal transplant, spinal cord injury, hepatic failure, or patient already on PPIs or H2 receptor agonists. If one or more is present, or whether two or more is present, if one or more is present of these, and two or more is present of sepsis, more than 1 week ICU stay, occult bleeding lasting at least 6 days, or high dose of steroids, that is more than 250 milligrams of hydrocortisone per day, so we will have to consider them. And the goes to is yes, that we have to check that whether the patient is already on a PPI, does the patient have a known peptic ulcer disease, and if there is any active GI bleeding. If the answer is yes, we start for PPI, and if the answer is no, then we can go for H2 receptor antagonist. So if we go for H2 receptor antagonist, then we see if the patient is nil by mouth, does this patient have severe dysmotility or ileus. If it is answer is yes, we can go for IV. If no, we can use the oral route. If we choose PPI, we have to see whether the patient has had endoscopic evidence of peptic ulcer disease and suspected UGI bleed prior to endoscopy, whether the patient is nil by mouth, and whether he is having severe dysmotility or ileus. If the answer is no, we go for oral route. If answer is yes, we choose the intravenous route. So this is an algorithm which can be easily applied on the bedside to decide upon the choice of stress ulcer prophylaxis in patients, and also understand or estimate their risk if it is not used. Now let us go back to the case that our patient is now on day 10 with a GCS of 13 by 15. Patient has recovered largely. Patient has weaned from mechanical ventilation. The enteral feed has increased from 20 to 40 mils per hour. The day 12 shows bowel distension, irritability, tachypnea. The bowel sounds are absent. and electrolytes are normal. So hypokalemia has been ruled out. So what is this cause of this ileus, delayed ileus on day 10? Now, again, we will have to understand that, as I mentioned before, the traumatic brain injury and, of course, the traumatic brain plus the intracranial hemorrhage also follows the same course, produces an intestinal dysfunction along this gut-brain axis because of various reasons. As we discussed, the gastric erosion, gastric ulcer, GI bleeding was one aspect. They can also increase in the intestinal permeability, which can lead to bacterial translocation, sepsis, and eventually multi-organ dysfunction failure. Exact mechanism of this increased intestinal permeability is not known, but this is believed to be an effect of multitude of factors. And it has been seen in various studies have tried to figure out the cause of this. In one study, they wanted to see the gastric myoelectric activity and check the electrogastrograms and found that severe head trauma patients have gastric dysrhythmias and food tolerance, whereas other studies have also found that the protective effects of cisapride and carbachol, that it is the vagal activity suppression from increased intracranial pressure that inhibits gastric emptying and produces a series of changes that manifests farther down into the intestine by affecting the peristalsis. Also, it has been seen that the intestinal behavior is influenced by ICH, that is the intracranial hypertension, constipation, and has no influence on increased ICH. So the gastric emptying changes may affect the enteric nutrition tolerance. This has also been observed. So it is a multitude of factors which ultimately lead on to a state of ileus in the intestine. And more recently, if you see that these are found in the earlier studies, they have largely blamed not only to the delayed gastric emptying, but they have also mentioned that there will be some changes of esophageal sphincter pressure, which causes reflux. Therefore, many patients of ICH are also like to have reflux of bile, etc. And that also increases the risk of ulcer, that also increases the risk of hemorrhage. So this reflux is another mechanism which can add up or produce the changes along the gut intestine axis. So the pathophysiological influence of sympathetic stimulation via gastric motility inhibitory effect and the ability of the intracranial hypertension to change this gastrointestinal dynamics is believed to be the major factor which produces the GI changes. So what are the therapeutic modalities for prevention and treatment of this post-operative ileus? So the treatment modalities can be divided into both non-pharmacological and pharmacological methods, and most of them have high quality of evidence. The treatments of non-pharmacological method include the which are probably beneficial is minimally invasive surgery, possibly beneficial is sham feed, early enteral feeding, whereas nasogastric decompression has been shown no demonstrable benefit, and early ambulation also, strangely though, has not found any demonstrable benefit. Among the pharmacological methods, the ones which were found to be beneficial is stop routine preoperative bowel preparation and epidural analgesia and multimodal fast-track approaches. Probably beneficial include limited IV fluid administration, preoperative carbohydrate loading, preoperative COX-2 inhibitors, and postoperative administration of opioid antagonist. So out of this, we can see that prokinetic agents have been considered, as also there is a high degree of evidence that it may be beneficial. So when we talk about the prokinetics and may be beneficial, we have to compare between metoclopramide versus domperidone. Metoclopramide 5 to 10 mg orally 30 minutes before meals and at bedtime. CNS adverse effects were more common with metoclopramide. Domperidone 10 milligram thrice a day, which can be increased if necessary to 20 milligram thrice a day, and at bedtime it should be avoided if the corrected QT interval on the patient's ECG is more than 470 ms in males and 450 milliseconds in females. In addition, we have several new generation of 5-TH4 receptor and agonists like prucalopride, Vulcertrag, Naronepride, and Felcicetrag, and these are also under study. Currently, they are not available for use. Another important aspect which needs discussion is the role of probiotics and prebiotics. Both probiotics and prebiotics are responsible for modulation of the gut microbiota composition and reduce the intestinal permeability, the lipopolysaccharide translocation, etc., which is largely responsible for increasing the severity of this disease once the gut axis gets affected. So prebiotics are mainly fructooligosaccharides, galactooligosaccharides, and bimmunogalactooligosaccharides. And probiotics, as we know, are the Bifidobacter bifidum, the Bacteria lactis, infantis, longum, Lactobacillus fermentum, and so on. So both have follow the different pathways. By the probiotics cause modulation of the immune pathways, neuronal and metabolic pathways, whereas the prebiotics cause increased neurochemical production of along these pathways. Finally, both of them act on the microbiota gut-brain axis, and this suppresses the effect of brain and reduces blood-brain barrier disruption along with other biochemical changes to reduce the neurological disorders, induced inflammation, mental problems, depression, etc. So they have been found to give benefit, although there is no conclusive evidence or clear-cut benefit has been demonstrated clearly in randomized controlled trials. The studies have suggested that various probiotic species and strains may have beneficial effects on gut motility and constipation, although they can cause diarrhea at times. Now, gut has many role in other neurological disorders, and if you look into the habits of the patients, like whether the extrinsic and the intrinsic factors, like the dietary habit, lifestyle, infection, exposure to certain agents during the neonatal period, or intrinsic factors like genetic, metabolite, immunity, and the hormonal characteristics that create the trait in an individual, they all influence the neurotransmitter release, the metabolites and their effects, the cytokines, the pathogen-assisted, the PAMs, and the neuroglial epithelial axis, which has a reversible reaction within the brain and the gut axis. So this is predominantly observed in various cerebrovascular diseases like atherosclerosis, multiple sclerosis, ischemic and hemorrhagic stroke, AV malformations, some neuropsychiatric dysfunctions like pain, migraine, anxiety, and autism or other spectrum disorders related to autism, as well as in neurodegenerative diseases like Alzheimer's, Parkinson's, and amyotrophic lateral sclerosis. So a mutualistic relationship exists between the gut microbiota and the host that aids in the digestion, drug metabolism, xenobiotic metabolism, and fight against pathogens, and improves the brain function. So like the brain can affect the gut, the brain is also dependent on the gut for its vitality up to a reasonable extent in various disease states. So to summarize, I need to say that brain plays a leading role in controlling gut functions with variations in motility, acid secretion, mucosal immune response, and ensuring proper maintenance of the mucus layer and the biofilm, because the mucus layer is our single most important layer which protects the gastric cells. So neurological injury combined with severe physiologic stress, critical illness, etc. has shown to increase the risk of GI ulcer dysfunction and ileus. Most regimens for gut prophylaxis are similar to that of the other critically ill patients, but it is useful to elucidate the optimal GI prophylaxis regime for patients at different ends of the practice spectrum. This is important because those patients who are at the higher risk of GI complications are likely to benefit most by the institution of this prophylaxis, that is stress ulcer prophylaxis. Thank you very much.